take a few minutes. I want to talk about CLEAR, and what that is that's our new accreditation system for graduate medical education. Just to give you a frame of reference, there are 117,000 residents and fellows nationally in ACGME programs. Locally, we have 33 FTE of residents and fellows at Methodist, and we have 133 residents and fellows at Regents Hospital. Those are ACGME-sponsored residents and fellows. We have about 30 non-accredited or separate programs. About a third of our trainees at Regents are Regents-sponsored. About 2/3 are university-sponsored and affiliated residents. So as mentioned, in the late 1990s, the Institute of Medicine report on patient and safety really sparked a lot of change in healthcare, which we know, but it really sparked a lot of change in medical education. The first change we saw was duty hours, and that was probably the biggest change that I remember to us as teaching programs. The second was looking at core competencies, and this is the next big change in medical education. It's called the Next Accreditation System. It really should be called a Now Accreditation System because we're in this accreditation system. This is for residencies and fellowships, and it's being phased in over a couple of years. We're currently in phase 1, and some programs are under the new process, and the phase 2 will start in July of 2004 of this year. What this does is it emphasizes the outcomes of residents. So not if they do so many months in the intensive care unit or so many months in the emergency room. It's really looking at the outcomes. And so they emphasize outcomes of the residents and fellow learning assessed by performance measures. Probably the biggest performance measure that's new are milestones. It's kind of a buzz term in education. And these are really behaviors or specific areas of knowledge that a resident is assessed over time, and the goal is to progress toward independent practice. Other performance measures, which we are still using, would be case logs for the procedure specialties, scholarly activities, and then exam pass rates. It's a little bit different. Prior to the Next Accreditation System, programs would have site visits, anywhere from 5 years if a program was in good standing to 1 year if a program was really in a tough spot or on probation. This has changed. This is almost a continuous accreditation system, to where there'll be scheduled site visits every 10 years. However, there's going to be an annual self-study that programs will submit to the ACGME. Part of this new Next Accreditation System is the CLEAR program, and it's the Clinical Learning Environment Review. And that's what I want to talk about a little bit. What this really is a set of guidelines or expectations for the teaching institutions. This is the first time we've been separate from the programs as far as accreditation. And it really places an emphasis on the institution in the 6 areas. So they want to know that we're teaching our residents and including them in patient safety, that we're adequately supervising our trainees, that we're involving the residents in quality improvement, that we're monitoring our duty hours and fatigue, and that we're teaching them about professionalism and transitions of care. And as it mentions up here, the emphasis is really on the sponsoring institution to focus on the quality and safety of the environment, the opportunity for our residents to be involved, and also for them to be aware of patient errors. The site visits will occur every 18 to 24 months. We have not had a CLEAR visit at Regents. Hennepin County is the only institution in town who's had a site visit. One thing that's really interesting, so what will happen is we'll get a 10-day notice saying they're coming for a review. And interestingly, what's different about this type of visit is the 2 key people that need to be there are the DIO, which is a designated institution official, so that's Felix Anklers, whoever oversees GME, but the CEO. And that's new, and what they're really looking at how do we bring together the hospital culture and the teaching cultures. What it does for me is it gives us a lot of areas for opportunity. The first is a collaboration of individual programs with hospital initiatives rather than us doing things in parallel. It really improves the understanding of GME at the hospital level and in the C-suite. Really will involve our residents in interprofessional teams and education. And what we're looking at is have residents and fellows better understanding our hospital system, so when they do graduate, they can integrate right in at the staff position.